Hello, everyone. Hi. Welcome to today's first webinar of 2026, titled Interpreting for Pediatric Oncology. We are so glad you have joined us today. Before we start, we want to hear from you. Please feel free to drop in the chat where you are connecting from. We love seeing how global our community is. Well, as some of you may know, but in case you don't know, my name is Analia. I am the manager of training and curriculum here at Cross Cultural Communication. I am joined today by my friend and colleague, Naisel Zabala. She's administrative support specialist. Naisel will be managing the chat and sharing helpful links throughout the webinar. Before we begin, we would like to share our upcoming training opportunities. The links to the training will be posted on the chat by Naisel. And just a reminder that CCC operates on Eastern Time. Okay, first upcoming training, Interpreting for Addiction Services. This online training will be held on January 31st and February 7th by our amazing Cindy Road. If you don't know Cindy, just Google it, Cindy Road. And like that was not enough, this workshop has been accredited the following continuing education units. So you will get 7 ATA, 7 CCHI, and out of those 7, 2 are performance-based. What a deal. 7 IMIA and BCMI, 0.7 RID, and finally 7 DSHS. Register by tomorrow and save $50. We only have about 5 spots left, so don't delay. Next, we are going to have the Community Interpreter International Training of Trainers. If you attend this online training of trainers program, you will learn how to lead your own sessions of the most widely taught national 40-hour licensed certificate program for community, educational, and medical interpreting. This training will run March 16th through April 3rd. Now, Interpreting Ethics in Educational Interpreting. This 90-minute self-paced course on interpreting ethics in educational settings, listen to this, walks you through real scenarios like IEP meetings and parent-teacher conferences. You will learn practical frameworks on handling confidential dilemmas and role boundary questions when ethical codes conflict. Last but not least, and listen to this. This sounds like the Terminator movie, okay? I hope it brings good memories, maybe some bad. This is our last training that I want to mention. The Rise of the Machines. Practical strategies to thrive along AI. This 2-session workshop is interactive and is designed for medical interpreters who want to move beyond word-for-word output and strengthen the human skills that machines cannot replicate, people. Through real clinical examples and guided practice, participants will learn how to convey meaning, context, and intent more clearly and safely, especially in complex healthcare encounters where machines consistently fall short. We know that, right? I know I'm preaching to the choir. Register by Thursday, February 3rd, and save $30. Okay, so hopefully you took note of all of that, and Naisel has been sharing the links. Okay, so how are things going to run today? This presentation will run 40 to 45 minutes, followed by 15 to 20 minutes of Q&A. Please, ladies and gentlemen, and everyone that is joining us today, use the Q&A feature to submit your questions to our presenter. For general comments or questions for CCC, please feel free to use the chat function and make sure that you set it for everyone if you would like for everyone to see your message. As we mentioned, those were the classes, but this webinar, yes, has been approved for CEUs, as we always do. And within 48 hours, you will receive an email with a link to download your certificate of attendance. Please be sure to check your spam or junk folder. Don't panic. Please check your spam or junk folder if you don't see it. Certificates are available only to the live attendees and must be downloaded within 3 weeks. Once downloaded, please remember to add your name and save a copy for your records. Now, okay, let's get started. We are delighted to welcome to our webinar our presenter Paul Spacek. Please join us, Paul. Okay, let me tell you about him before he takes over and starts the webinar. Paul is the Education and Development Program Manager for Language and Accessibility Services at Children's Mercy Hospital, where he has worked for 12 years. In this role, Paul serves as a coach, mentor, and instructor for interpreting students, new hires, and staff interpreters, and is also involved in the development and presentation of continuing education workshops and webinars and community outreach. I love it, Paul. Additionally, he designs and presents educational materials for hospital system about how to work with interpreters, so much needed, by the way, and provide better care to limited English proficient families. Paul is a nationally certified medical interpreter through the Certification Commission for Healthcare Interpreters. He holds a bachelor's degree in Spanish from the University of Kansas and a certificate in medical interpretation from Johnson County Community College. And ladies and gentlemen, if this was not enough, he has a master's degree in adult learning and leadership from Kansas State University. Paul has presented previously at medical interpreter conferences, including MICARA, NATI, CCHI, and NCIHC. Paul, we are honored to have you today. I cannot say enough, but the floor is yours. I'm going to go away and let you get started. Thank you, Paul.
Well, thank you very much, Analia. I really appreciate that. And I was just looking at the chat as it was coming through there, and I saw some people saying Rock Chalk Jayhawk, go KU. So I support that very much. All right, let's, for those of you who might have seen the KU game last night, they beat number 2 Iowa State. So very, very happy about that. All right, let's get this started here. Again, thank you very much for having me to Cross Cultural Communications, Analia and Nysel. I'm going to start out by apologizing for my voice. I am getting over a cold, so I don't sound 100% of my voice, but I'm going to do my best. And I'm sorry, okay, perfect. All right. Well, so today we're going to talk about interpreting for pediatric oncology. And start out by giving a special thanks to some people in my organization. That includes Pilar Coromina. She's one of our bilingual patient guides here at the hospital. Also, Dr. Tristan Flatt is a pediatric oncologist here at Children's Mercy, who is Spanish speaking. And he was a big help to me, as well as Dr. Berenice Casanova Gonzalez, who works with Dr. Flatt. And really, this content is part of a webinar series that we've done at our hospital that's interpreting for and then many different pediatric subspecialties. But we decided to tackle oncology because we were getting some feedback and some concerns from the oncology clinic of wanting to make sure that our interpreters were well trained on the words and topics that they would encounter in that clinic. And so we worked together with that clinic to create this content to make sure that our staff is well trained and well prepared for what they will encounter there in that clinic. Okay, so I'll skip my introduction slide here because Analia already did a wonderful introduction that made me blush. Coming here to our purpose and objectives for our webinar today. First is to discuss the importance of interpreters as a part of the pediatric oncology care team. I know I will not have to do much work to convince this audience that interpreters should be thought of as part of the care team and not as a tool, right? But I will go a little bit more into that. That's one of my big passions. We're going to explore some of the 5 most common types of pediatric cancers, talk about common treatments and complications that can be encountered. We will review specific vocabulary, cultural, and ethical issues related to pediatric oncology. Okay, so my introduction here. My philosophy when it comes to medical interpreters is that it is important for us to have at least a basic understanding of what we are interpreting, right? Because I'm sure we've all been there in situations where someone is talking about, a provider is talking about something that you have never heard of before. And yes, you can do your best of just interpreting the words as they're coming to your ears and just saying them as you hear them. But if you don't at least have a basic understanding of what is being discussed, there's a lot that's going to be lost in your interpretation. So I know that this is a field, oncology, and especially pediatric oncology, that may be unfamiliar and perhaps uncomfortable to a lot of people. But I think it's important that we at least have a minimal understanding of some of these concepts if we're going to interpret in this setting. Okay. I want to make it clear, yeah, as interpreters, we have to know a little bit about a lot of things, right? So I think here in our hospital, we often say the interpreters are some of the only people that have been in every single clinical area throughout this entire hospital. I know I have been in every clinic, if not even every clinical room in this entire institution, which is wonderful. I mean, when I'm interpreting, I never know what I'm going to expect, where I'm going to go in a given day. That's awesome, but that also means that we have to have a wide breadth of knowledge. So we don't necessarily have to have a large depth of knowledge, but rather a wide breadth. So I am not a doctor, though this information was reviewed by Children's Mercy doctors. So if I'm talking about something as we go and you're interested or you're curious or you want to know more or you think something I said isn't exactly right, that could be possible. I really encourage you to do your own study and your own research. My goal with presenting a lot of this information is not for it to be complete or definitive, but really rather just to be an introduction and an overview. We're going to cover a lot of information. We're going to move pretty quickly. So, don't try to absorb everything. My goal, my philosophy here is I understand I am a medical interpreter. That's my experience, that's my background, and I know that that's my audience today. So I'm going to be talking about things that I think at the level that I think is relevant and applicable to medical interpreters. So some of you might have some background and experience in the medical field beyond just interpreting, and you may think he's not going really in depth on some of these things. Well, that might be kind of on purpose. I'm going to try to throw a lot of information at you. My idea is to hopefully pique your curiosity and encourage you to go out and research more. And being familiar with these concepts can help to mitigate the emotional weight of things that we're talking about, right? Because a lot of these conversations that you're having could be sad, could be difficult. If you're dealing with those emotions, and on top of that, you're hearing information coming at you that you think, what is this? I don't even know how to say that. I've never heard of this before. It can be even more complicated. Okay, so we're going to start off with our introductory poll, and we're going to ask 2 questions just to kind of give me an idea for our audience here. How much experience do you have in pediatrics, and how much experience do you have in oncology? So A is no experience, I'm brand new. B is less than 3 years. C is 3 to 10 years. D is more than 10 years. So I'll give you all a little bit of time to answer that on the poll.
Oh, this is Nicelle. If you try to change the display settings, we're currently seeing your notes.
Okay, thank you. Is that better?
Yes, thank you.
Okay, I'm seeing a lot of the responses come through, seeing a lot of mix. So that's great to know that we've got people with a lot of levels of experience. I'm seeing many people saying C and D, so 3 to 10 or more than 10 years. So that's great. That's telling me that we've got a lot of mix of experience here in the audience. Okay. So moving to our next slide here. All right, I'm seeing some 10 plus on both. So, okay, that's good. So why oncology? Why is this a topic worth us discussing? So the data that I was looking at was from 2024. In the United States, about 9,620 children under the age of 15 were expected to be diagnosed with cancer. Cancer is the second leading cause of death after accidents for children ages 1 to 14. Now, due to wonderful advancements in medical treatment, about 85% of children with cancer now live 5 years or more after diagnosis. That is amazing, right? That we have had that growth and development of treatment over time. And the process of diagnosis to treatment can be long and challenging, especially for those with language barriers. So I think the point that's worth taking away here is that the medical system and medical care has improved substantially, and that is what has resulted in better care and better outcomes for these children. Now, for those of us working within this system, it is important that we are familiar with it, that we understand how some of these things work, and that is going to help contribute to these positive outcomes for these kids. And I especially think for us as interpreters, having familiarity with the topics and having that confidence when we are in these situations has a lot of benefit for the patients and families. I have seen it in many situations where, families are coming in, they're going through a difficult time with this diagnosis. This is all new, unfamiliar, and scary for them. But then when they see that those of us in the room, of course, we are, we feel for them, we have compassion for them, but this is also pretty routine for us, right? We're used to this. We do this every day, and sometimes that is really reassuring to our patients and families of knowing, okay, these people know what they're talking about. They know what they're doing. They're experienced. They've seen other children like my children. And that really, you know, um, helps them have more confidence in the care team and confidence that their child's going to be okay. So I think the way that we are able to portray and show that confidence is by gaining that experience, by studying, by learning, by practicing. So that's why this is an important topic for us to talk about today. Okay, so what is cancer? Let's start there. So cancer is a disease of abnormal cell growth. So we know that typically the cells in our body, all of the cells in our body, grow, split, divide at a pretty normal, controlled rate. However, when a process of cancer is occurring, that's when a group of cells are reproducing and growing at an uncontrolled or overly fast rate. And this can occur anywhere in the body. So cancer can affect organs, bones, blood, or the brain, depending on the particular type of cancer. Now, a tumor is a growth or an overgrowth of cells. An important thing here is that not all tumors are cancerous. So tumors are typically categorized as being either benign or malignant, right? So those are terms that we should definitely all be familiar with. A benign tumor does not spread, whereas a malignant tumor can evade nearby tissues and spread to other parts of the body. So often think malignant. Malignant is synonymous or can be synonymous with cancer. Now, cancer in children is different than cancer in adults. Pediatric cancers often involve different types of cells and may respond differently to treatments. And an interesting thing here with pediatric cancer is that often the cause of the cancer is unknown in pediatrics. So unlike adult cancers, pediatric cancers are rarely linked to lifestyle or environmental factors. So we think oftentimes for adults that sometimes certain cancers can be related to lifestyle choices such as smoking or diet or other things like that. That is typically not the case in pediatric cancers. So next, we're going to talk about the importance of interpreters. Again, I know I don't need to convince this audience that interpreters are important, but I will take every opportunity I'm given to advocate for interpreters being seen and respected as part of the care team. And I think that having interpreters present, can allow for the formation of trust and relationships between patient and provider. But I also think that the interpreter having trust and a relationship with the provider, with the care team, and also with the family or with the patient can play an important role. And this is an area I know there might be some, maybe disagreement isn't the right word, but I know in this audience today, we have a variety of interpreters who work in different settings, right? We might have interpreters who are staff interpreters who work for an institution like myself. So I will admit from the bat, that is my bias, that is my point of view. But I recognize there might be many people here who work as freelance interpreters for agencies, and that could be in person or perhaps also remote. And I recognize that if you are working for an agency rather than for an institution, and that if you are working remote, either video or phone, your particular role in the scenario may be different than if you are a staff interpreter. So I want to say that I'm not here to say that one role or one conception of the role of interpreter is right or the other is wrong. I'm just going to talk about my experience and my opinion based upon my own experiences working in the hospital for over 12 years. I have some other concepts up here that I think are really important, and I think that interpreters can help to accomplish. The first is cultural humility. Now, maybe some of you are more familiar with the term cultural competence rather than cultural humility, but I really like this second term, cultural humility, because with cultural competence, it maybe implies that, if you take some trainings, if you go to some workshops, then you can achieve cultural competence, right? And I think that cultural, understanding and awareness is a lifelong endeavor that we will never be complete, with, right? And so I think it's better that we always approach cultural issues with a sense of humility, of knowing there's a lot that I don't know. And even if I think I might know, my understanding might be different than your understanding. So we must approach always with humility and let our patients and families be the experts and the explainers of their own culture. And I think often interpreters can help to create the space to allow that to happen. The next is health literacy. So that's presenting information in a way that is meaningful and useful to our patients and families. I always think about this, and when I'm training new interpreters, I will tell them this. The number one thing that I do not want when we are delivering a new diagnosis to a family, when we leave that room, okay, I know that that parent is probably going to call somebody, their mother, their father, their spouse, their sibling, their friend, and they're going to say, we're at the hospital, just talked with the doctors. And I know that the first thing that that person on the phone is going to ask them is, well, what did the doctors say? And what I do not want that parent to say is, well, I don't know. They said a lot of different things. They used a lot of complicated words. They said that he's sick. They said we might have to do this and this, but I'm not really sure. I want to equip the patients and families that come here to our hospital with the words and information that they need to understand their child's diagnosis and illness and treatment plan, and then to be able to share that information with their friends, families, and loved ones. So in order to accomplish that, we have to know the things that we're talking about at different levels of health literacy, knowing, the high register words, but maybe also knowing the simplified words and making sure that we're really equipping our families with the information they need to take the best care of their children. Having interpreters present can help to provide an accurate history. I wanted to include that because I thought that's super important with cases of cancer. As we will talk about a little bit later on, some of the initial signs and symptoms of certain types of cancer can be quite general symptoms, and they can be easily confused with other disease processes. And so it is crucial for the care team to know, when did symptoms start? What were the progression of symptoms? How long has this been going on? And having that information can allow them to know which tests might need to be ordered, what sorts of images or studies need to be done. Lastly, I have on here advocacy and navigation. And again, this might differ depending on your particular role within your institution. But I know for our interpreters, again, I stated that we go everywhere in the hospital. So we know this hospital front and back, oftentimes better than other people. So there'll be situations where, in the course of an appointment, someone says, oh, I don't have health insurance. I need to find the financial counselor, or I need to go to the pharmacy. And there are times where I've been in clinics where the providers don't know where those things are in our own institution. So I've been able to speak up and say, yes, I know where this is. I can tell you, or even after the appointment, I can walk you there. So I think that interpreters can serve a wide variety of roles in these contexts. Okay, so the first thing that we're going to talk about here is who is a part of the care team. And I wanted to include this because in my time of training new interpreters, I've often found that people will struggle with the titles of different people who are part of the medical care team and how to say that in the target language. So as I'm talking about this, I really encourage you to, as you see these different titles, think about how would you say this in your target language. And this can be difficult because there'll be times when people with different titles really appear to be doing similar or the same work. So I think oftentimes nurse practitioners, I will hear some of our patients refer to them just as doctor or doctora, doctor, because they're prescribing them medications, they're doing physical exams, they're making referrals. For all intents and purposes, they're really like a doctor to that patient and family. But I still think it's important that we are saying the correct interpretations of their titles so that we're never inaccurately portraying who this particular person is that the patient is speaking with. So let's just talk briefly about some of these titles of providers. So first I have a pediatric oncologist. So onco, that's the root word for referring to cancer. So an oncologist is a physician specializing in cancers. Hematologist, that hema that refers to blood. So they're a specialist in blood disorders or in cancers. So especially in the pediatric setting, we will refer to our clinic here as the Hematology Oncology Clinic, or oftentimes HEMONC for short. And that is because, we'll get into this, but a large proportion of the patients that we see in our clinic do have leukemia, which is a type of cancer, but also a type of blood disorder. So they are treated by hematologists and oncologists. Okay, next we'll talk about nurse practitioners. So that is, they provide an advanced practice nurse. So that's often a master's level nursing professional. They will oftentimes work closely with physicians and will see patients oftentimes on their own. We will have in the clinic nurses. You might have patient navigators. At our hospital, we have a position called bilingual patient guides. So these are interpreters who've been trained to do some navigation work as well. So they will help families to navigate the hospital, access the different resources that we have for patients and families, but then also sometimes they will be involved in highly acute cases so that we can have some of that continuity of care. Those many hospitals I've learned have positions like that, but we tend to all call them different names. So it's important for you to be familiar with what is the particular nomenclature that is used at the institution in which you work. Next, I have child life specialists. We work with them a lot here at our hospital. They are common in pediatric institutions, providing emotional and psychosocial support to children. They can often help to explain things to children in a way that they can understand using visual aids or things like that. Okay, I glanced quickly at the chat and I saw a question about for nurse practitioner. In Spanish, because that's my working language, I prefer enfermera especializada o de práctica avanzada. That way we are, so like specialized nurse or advanced practice nurse. That way we are making, and because I have heard some students or people say enfermera practicante, because it sounds like practitioner, but to me in Spanish, that sounds like you're saying a person is a trainee. So I'll mention that there. I see that there's other questions. If I stop to answer all of them, I'm not going to get through all of this content here. Just to finish off, also when working in a pediatric oncology unit, you might interact with social workers, pharmacists, dietitians or nutritionists, psychologists, and many more. So I think it's just important that we know that you're going to interact with a wide variety of healthcare professionals and that we work as a team. And I really think that we should be seen as part of the care team just the same as all of these people that are listed here, because we have an important role to play when the patient and family is limited English proficient. Okay. Next section, we're going to talk about types of pediatric cancers. And like I mentioned before, certain types of cancer can be more common in pediatric populations than adult populations. And different types of cancer may have different prognoses and treatment options. So prognoses, if you're not familiar with that term, that is the prediction basically made by the care team of what the possible outcome for this child might be or for this patient might be. It's important for us to be familiar with these common types and to know the correct words to use. I'm going to say for this section, intentionally, I will be overwhelming you with information. We're going to talk about a lot of things. Just try to look and hear some of the different words and really think about how you would say these things in your target language. And if there's anything that, as we're going, you go, that's confusing, that's interesting, write that down to look up later. Okay, so we're going to start off this section with a poll. And I'm going to ask you which of the following is not one of the top 5 most common types of pediatric cancer. So this will just kind of give me an idea of people's understanding of this topic to start out with. Okay. Great. I'm seeing a lot of people responding the correct answer, which is C. And so we're going to go ahead and get into, and that is because oftentimes that is caused by environmental factors, right? Or lifestyle choices, which we talked about that pediatric cancers typically are not caused from them. Okay, so we're going to start off here with leukemia. Leukemia refers to cancers of the blood and bone marrow. Now, bone marrow is where blood cells are produced, right? So what happens in the case of leukemia is that there's an issue in the blood marrow, and instead of producing correct blood cells, your red blood cells, white blood cells, other blood cells, it produces faulty blood cells, which then take up space and cause issues with the other blood cells to be able to do their job. And it produces an overgrowth of these faulty blood cells. So that's a way to kind of think about leukemia. So leukemia is a little bit different, that it's not referring to a tumor growth in the same way as some of these others that we are going to be talking about. Leukemias account for about 28% of all childhood cancers. The most common types are acute lymphoblastic leukemia, often referred to as ALL, and acute myeloid leukemia, often referred to as AML. So Luke, the Leuk, again, I'm going to be talking a lot about word roots, prefixes, and root words, prefixes, and suffixes, because again, I'm a medical interpreter. You all are medical interpreters. So that is going to be our focus on the medical terminology. So LEUK refers to white, like as in white blood cells. So it's referring to, again, issues with the production of correct white blood cells within the bone marrow. So first signs and symptoms of this can be fatigue, pale skin, fever, easy bruising or bleeding, bone or joint pain, and swollen lymph nodes. The common age group, ALL is most common in children aged 2 to 4 years old. Survival rates, I'll have them listed out here, can be approximately 90% over 5 years to ALL, can be slightly lower for AML. Treatment options often will be chemotherapy, could be radiation therapy, or even stem cell transplant. Again, for a lot of these, I'm not going to go in depth. I would encourage you to think, how would you say them in your target language? And if you're curious to learn more, please look them up. All right, this next slide I included based upon feedback from the pediatric oncologist that I work with, because one of his big focuses, Dr. Flatt, is that leukemia outcomes are different in Latino populations. And I know that, here on the call, we have people who interpret for many different languages, but I thought that this would be interesting to this group here. And after this doctor told me about it, I started doing some reading and found a lot of statistics backing up what he was telling me. That Hispanic children with leukemia generally have lower survival rates compared to non-Hispanic white children. A large study published in the JAMA Pediatrics found that Hispanic children had a 34% higher risk of death compared to non-Hispanic white children, even after adjusting for other factors. So I see someone asking why. Number of reasons. The first listed here, cytogenic and biological differences. So some Hispanic children have been found to be more likely to have high-risk cytogenic genetic profiles and central nervous system involvement, both of which can be associated with poorer outcomes. Now, I don't know as much about that, but I do have a little bit more insight into this next reason, which is socioeconomic and access factors. And so some of these disparities can also be driven by social determinants of health, including limited access to specialized care. Perhaps if you live in a rural area or not close to, a larger pediatric hospital with a specialized oncology unit. Delays in diagnosis or treatment initiation. If you don't have insurance, if you don't live near a hospital, if you are afraid to go seek care, these could all be reasons why you might put off seeking care for something like this. Lower rates of clinical trial participation, perhaps if you don't understand what the clinical trial is, or maybe you weren't offered because they didn't have the resources or information in your language. And language barriers and insurance coverage issues. Treatment adherence. Now, this is interesting. I'll read this and then I'll say what Dr. Flatt told me. So studies suggest that treatment adherence may be lower in some Hispanic populations, potentially due to socioeconomic stressors, cultural differences, or healthcare system navigation challenges. Now, when I asked Dr. Flatt about this, he told me that he rarely ever has issues with his Latino patients when it comes to following through on what he tells them to do or instructs them to do. He says they are very compliant, want to listen to his instructions, very willing to do everything that it takes for their children. But he does see a lot of these things that are mentioned here, the socioeconomic stressors, the difficulty navigating the healthcare system, those types of things. And I think those are often some of the largest factors. So while survival for all children with leukemia has improved over time, the gap between Hispanic and white children has persisted, especially in adolescents and young adults. And from my experience of what I've seen over the years, I think that a lot of these factors do play play a large role. Okay, moving on here, the next category is brain and central nervous system tumors. Those are tumors affecting the brain and spinal cord. Signs and symptoms can be headaches, dizziness, balance problems, vision, hearing, speech issues, frequent vomiting. Common age group can occur at any age, but certain types can be more common in specific age groups. These tumors account for about 26.5% of childhood cancers. Common types can include medulloblastomas, gliomas, and ependymomas. Even I have a hard time with that. Just if you're not familiar with some of those terms, a medulloblastoma is a fast-growing malignant brain tumor originating in the cerebellum. A glioma is a growth of cells that starts in the brain or the spinal cord and can grow or spread. And an ependymoma are tumors that develop from ependymal cells lining the brain's ventricles and spinal cords. Again, if that is confusing or difficult to you, I would encourage you to read more and learn more about those things. Survival rates can vary widely depending on the type and location of the tumor. For example, medulloblastomas can have a 70 to 80% 5-year survival rate, whereas brainstem gliomas have a less than 30% survival rate. Treatment options can include surgery to remove as much of the tumor as possible, radiation therapy to target the remaining cancer cells, and chemotherapy can be used in combination with that. Again, like I said, this section we're going to be moving quickly through. So next we're going to talk about lymphomas, which are cancers of the lymphatic system. So lymphatic system is part of the drainage system of our body. We have lymph nodes all throughout our body. Think commonly kind of in the neck, behind the head, in your armpit, in your groin. So some of the first signs and symptoms can be swelling in those lymph nodes, fever, night sweats, or weight loss. So often when we're talking about lymphoma, you'll hear the categories of Hodgkin's and non-Hodgkin's lymphoma. So as I was doing research for this, I was thinking, well, what is the difference between Hodgkin's and non-Hodgkin's lymphoma? Well, unfortunately, the difference isn't simple, but I will read quickly what I found. So the main difference is that Hodgkin's lymphoma has a specific type of abnormal cell called a Reed-Sternberg cell, which doctors can see under a microscope. And a non-Hodgkin lymphoma does not have this cell and includes many different subtypes that can behave in different ways. Hodgkin lymphoma usually starts in one group of lymph nodes and spreads in a more predictable pattern, whereas non-Hodgkin's lymphoma can start almost anywhere in the body and spread less predictably. So both types can be serious, but they are treated differently depending on the exact diagnosis. And again, when you're interpreting in these settings, this information is all going to be coming from the care provider, right? And if the family doesn't understand something, then they should ask, and we can help them ask, and then that explanation can come from the provider. My goal really is just for you all to hear these words and have some familiarity. That way, if you encounter it in the real world in your practice, you at least go, oh, I feel like I've heard this before. And because I heard it, I went and looked it up. So that's really my goal in presenting this information. So here are some of the survival rates and treatment options for lymphomas. They are similar to some of the ones we've talked about before. Keep moving along here. Next, we're talking about neuroblastomas. So that is a cancer that develops from immature nerve cells. So we see neuro, we know that we're talking about nerves. We see oma, we know that we're talking about a tumor or a growth. So again, having that knowledge of medical vocabulary can help you kind of even guess what something is talking about, even if you've not heard that term before. So first signs and symptoms can be abnormal pain, changes in the eyes, difficulty walking, high blood pressure, things like that. They are most common in children under 5 years, and this is actually the most common cancer in babies under 1. Now, I know that is surprising to some people when, thinking that children that young can get cancer, but it's true that they can. Now, I just saw in the chat somebody asked, why we're talking about things in 5-year survival rates. That is commonly how it is talked about, or at least in the information that I found, especially when we're talking in pediatrics. Now, it doesn't mean that after 5 years, they are expected to pass away or anything like that. But I think, in cases like this, they tend to look at the short term, medium term, and long term. And so that's typically what we're looking at is the 5-year survival rates. And again, neuroblastomas account for about 6 to 7% of pediatric cancers. So again, survival rates can vary widely based upon the risk categories. Again, treatment options can be similar to the other types that we've talked about. So I hope you're seeing generally, although there are different types of cancers that can have different outcomes based upon where they're located, how fast they spread, oftentimes the treatments can be similar. All right, next one I will mention briefly here. These last couple I'm going to go through pretty quickly. A Wilms tumor. This is a type of kidney cancer that can occur in children. The first signs and symptoms can be abdominal swelling or a mass, like also fever or blood in the urine. Typically affects children aged around 3 or 4, accounts for about 5% of childhood cancers. Something I want to mention here, Wilms tumor. You might see that word Wilms and think that's an odd word. Likely that is the name of the person that discovered the tumor. So, a lot of medical terms, diagnoses are named after the doctor or doctors or people that discovered this. When we're interpreting that, it's often going to be the same in that target language because it is a proper name. So sometimes it can be even helpful if you're hearing, the doctor says your child has a Wilms tumor. As the interpreter, you might even want to clarify quickly, doctor, does Wilms refer to a person's name? That way you're not thinking an eponym. Thank you for the person that put that there in the chat. That way you're not thinking, oh, what Wilms? What does Wilms mean? How do I say Wilms? But okay, no, that's just a name and I'll keep it the same in the target language. Survival rates, again, are listed here. Treatment options, similar in the others. Have the last two here. This one I wanted to include this rhabdomyosarcoma that is a cancer of the muscle tissue. And again, what I wanted to use this as an example of how we can break down a term with its root words and prefixes and suffixes to kind of understand what it is. So rhabdo means rod-shaped. So that's referring to the striated or striped appearance of muscle cells. Myo then means muscle. Sarc then means flesh or tissue, and oma means tumor. So therefore, the term describes a tumor of the muscle tissue with a rod-like or striated appearance. So again, just being familiar with these helps you kind of break it down in your mind. That way, if you get thrown this term, maybe you've never heard of a rhabdomyosarcoma before, but you might at least have a little idea of what it means and have an idea of how to say it in your target language. For me, at least as a Spanish speaker, I can then look at that and go, okay, it's probably going to be rhabdomyosarcoma, So that is helpful to have that familiarity with those medical terms. Okay, I'm seeing some of these things come in the chat. I'm going to be excited at the end to go read through what some people are saying. I see there's some good conversation going on. Okay, again, approximately 70% 5-year survival rate, and here are some of the treatment options. All right, last one here in this section, retinoblastoma. So again, retino referring to the retina, blast referring to irregular cells, and oma referring to a tumor. So it's a tumor of immature cells in the retina. First signs or symptoms could be discoloration in the white of the pupil, eye redness, vision problems, typically diagnosed in children under 5, accounts for about 2 to 3% of childhood cancers. Again, we have survival rates and treatment options. So, all right. Ooh, we made it through that section. Give yourself a round of applause there. Feel free to stand up and stretch. I have a take two for the poll here to make sure we're all paying attention. So again, which of the following is not one of the top 5 most common types of pediatric cancer? We'll try this again. All right, this time I'm seeing a lot of C's. That's great. And that is correct. All right, so everyone was paying attention. That's good. I haven't put you guys to sleep. All right, feeling good about that. Okay, going on to our next section here. I'm going to talk about diagnosis and initial treatment. So the initial evaluation, of course, is going to include a discussion of symptoms, medical history, and a physical exam. Now, a lot of children, when they are first presenting, when they have cancer, the family is not aware that that is actually what's going on. And of course, that is the last thing that any parent wants to think that their child might have, right? And so a lot of times parents are bringing their children in for other symptoms. And a lot of times these symptoms can be general or easily confused for other diseases, as we talked about in that last section. A lot of those symptoms that we were listing could be attributed to something else. So again, it's important that interpreters are there so that all of the correct information is delivered to the care team. They're able to ask all of those questions and get that information that they need. Based upon that information, they may choose to order some diagnostic testing. That could include blood tests, imaging such as X-rays, CT scans, MRIs, could include biopsies, and lumbar punctures. Then, if cancer is suspected, the child will be referred to a pediatric oncologist for further evaluation, diagnosis, and treatment. So, here I just wanted to mention an anecdote from an experience that I had several years ago that I will just always remember. So I remember I was called to triage for a patient, little boy, probably 4 or 5, and he had pretty general symptoms. He was pale or pallid. He'd been kind of lower energy. And I always remember the mom said, well, we moved recently, and so I think he's just been kind of sad about the move. And I think that's really kind of just what's going on with him. But we just wanted to bring him in to get checked out. And, I've seen hundreds of patients in triage, hundreds of patients in the ER. And initially, I didn't really think twice about this particular patient. I thought, oh, I've seen many other patients that have these types of symptoms. Well, as they got worked up, and they're in the emergency room, the care team started to become concerned. And the thing I remember is that they ordered some blood work. The initial blood coagulated in the test tube, so we had to go back in and talk to the parents and say, we need to draw further blood. And I could tell in that moment, the mom was starting to get a little nervous because she could sense that the care team was concerned. So she was getting concerned and she started saying, you know what? We're kind of tired. It's been a long day. Can we just go home? We'll come back tomorrow. This has been a lot. I don't think I want you to stick him again. But again, I was glad I was present to be able to interpret and really convey to this mother that the care team was concerned and that it was very necessary that this blood work got done there in the emergency room because there was real concern that there could be something else going on. So she consented to it. We got the blood drawn. The results came back, and the child did have leukemia. So I was working an evening shift that night. So I was working, like 3 to 10. And so I'd seen them first when they came in right in the afternoon in triage. Well, that night they got admitted and we were signing consent forms for him to go to interventional radiology the next morning to get a port placed. So that was just really whiplash for the family, but really for myself too, because, I had seen that child in triage, thought everything seemed routine. And that night we're getting admitted and getting ready for port placement and starting with treatment the next day. And so again, I just share this anecdote for you to be aware that sometimes when things like this are discovered, it moves fast. it can move very fast and families might be very disoriented. So having the interpreter there, a person that they trust to deliver that information to them, to help get their questions answered, for them to be involved in that process. Because again, when this process is moving so quickly, it can be very alienating for the parent and for the family. So I think it's crucial that we are there in this initial stage of the treatment. Okay, so then extended treatment journey, cancer treatment is not a one and done thing. This can be a long process and a long journey for that patient and family. And the time that it takes can vary significantly depending on the type, stage of the cancer, and treatment plan. There are different phases of treatment. We'll talk about that on the next. Throughout a treatment process, there can be planned and unplanned admissions and outpatient visits. Oftentimes we're sending our patients home with these detailed calendars that say the days that you need to go in order to, receive your different treatments and things like that. Families are often given precautions for when to go to the emergency room. So that's often in our parlance, return precautions. Those can include fever, infection, bleeding, pain, vomiting, diarrhea, difficulty breathing. And it's very important that our families know what are those things they need to be looking out for in their child, and what are the steps that they need to take if they see those things. Because sometimes we instruct them to call the oncology clinic first and then head into the ER. That way the oncology team can alert the ER that this patient is coming, because especially in the wintertime in our emergency department, I mean, it can be packed out and busy. There can be waits of 2 to 3 hours. But if you have a child that has cancer coming in because there's concerns, that child might need to get triaged and moved back in the emergency room quickly. So it's important that there's that good communication between the care teams so they know how to handle that child. So phases of treatment. You might hear care team talking about that. So the first phase of treatment is diagnosis and staging. So that's identifying what type of cancer is that the patient has. Okay, I keep glancing over the chat. I saw someone asked, when you instruct, again, they said, is that the care team instructing or is that the interpreter instructing? It is the care team instructing. I am somebody that believes that the interpreter can have a role to help for advocating for the family, but I believe that our role is to be the conduit for the care team. And we should let those messages come from the care team. And so that should be coming from them, not coming from us. We have a very important role, but it is a designated role in the care team. So we should not be stepping on the toes of the care team. Now we can help advocate if something is not communicated well, if the family has a question, we can redirect it to the care team, but we should not be putting ourselves in the position of answering for the patient or for the care team. Okay, so in the first phase, we're delivering the diagnosis. What type of cancer is it, and what stage is it in? And we'll talk a little bit more about stages later on. This next phase is induction. That's what the oncology team will typically call it. That is initial treatment. So the goal in induction is to kill as many cancer cells as possible and bring the disease under control into remission. This phase often involves intensive chemotherapy. The next phase is consolidation or intensification. So after remission, this phase aims to destroy any remaining cancer cells and prevent the cancer from coming back. The next is maintenance therapy. So that involves lower doses of treatment given over a longer period to help keep the cancer from returning. This is very common in leukemia. Next I have listed supportive care. This can be really at any phase of treatment, but we know that both cancer and its treatments can have many effects on a person's physical body. So we'll talk about this a little bit more when we talk about chemotherapy, but it might be necessary for a child to be given medications for nausea, for mouth sores, for other things related to both the disease and the treatment. And lastly, follow-up and survivorship. So even when a cancer is in remission or largely eliminated, excuse me, there's still always a risk that it could come back. So it's still important that these patients have follow-up with an oncology clinic. All right, we're going to do next poll here, and we're going to talk about 3 terms that come up often in cancers. So we're going to see how much people understand about these terms. So first, what does metastasis mean? Is it A, the spread of cancer cells from the original site to other parts of the body? B, the shrinking of a tumor after treatment? C, a benign growth that does not invade nearby tissues? Or D, the body's immune response to attacking cancer cells? All right. Well, I can tell that this is an experienced group because I'm seeing lots of A's, so that's great. All right, the next question that's on your poll here is, what does remission mean? So is it A, when it spreads quickly to other organs? B, when it's resistant to treatment? C, when signs and symptoms decrease or disappear? Or D, when it returns after being cured? Okay, again, we've got a very experienced audience because I'm seeing lots of C's to that one. So that is correct. C, remission is when cancer signs and symptoms decrease or disappear. And that's key because oftentimes, even if it is in remission, it doesn't necessarily mean that it's completely cured or gone away. So that's an important thing for us that families understand. All right, the last poll question here. What does staging mean? Is that A, preparing a patient for surgery, B, grouping patients by age and diagnosis, C, measuring how well they respond to treatment, or D, determining how much cancer is in the body and where it is located? All right, I'm seeing lots of D, and so that is the correct answer here, determining how much is in the body and where it is located. So great job, everybody. Again, I enjoy seeing this because that tells me this is an experienced group of medical interpreters here on this call. So let's go a little bit more into these terms. Again, it's important that us as interpreters understand these terms and that we're able to use the correct words in our target language for them. So metastasis is the development of secondary malignant growths at a distance from the primary site of cancer. So that means that it is spread to a different area or location from where it was initially. Remission is defined as the absence of detectable cancer cells after treatment. Now, I want to contrast that with the word cure. So parents always ask, is there a cure? Now, they sometimes will use that word, so it's considered when a child remains in remission for a certain period of time, typically 5 years. But even if a child is considered cured, there still is a chance for recurrence. That's another important term for us to know, meaning that the cancer has come back. And then the last one here, stage, that's a way to determine the extent of the spread of cancer within the body, its size, location, and where it has spread. You'll often hear terms of stage 1, 2, 3, or 4 that will come from the care team as far as then that tells you about its spread. All right, in the oncology clinic, we're often going to be having difficult conversations. So the diagnosis and treatment process can be long and difficult. It can be highly emotional when we're disclosing the diagnosis and talking about treatment options. The important thing here in pediatrics, sometimes a family may choose that they don't want the child to be present for some of these discussions. Sometimes they do. Sometimes they'd rather the child be present later and that we explain it to them in a way that they can understand. That's going to be different for every family. End of life discussions with the palliative care team, chaplaincy, or social work can again be highly emotional. And I often think this is some of the most difficult type of interpreting to do in a medical setting. So I will often differentiate 2 types of interpreting, what I call question and answer interpreting, which is often what happens in the emergency room, right? Have you had fever? Yes, no. Are your vaccinations up to date? Yes, no. And those types of things I often think are easier for interpreters versus what I call narrative interpreting. And that's more, tell me how you feel about your child's diagnosis. So if you ask a question like that, you're likely to get a paragraph response from a parent, right? And that's going to be a difficult thing to interpret for an interpreter. So being prepared for that type of interpreting. Psychosocial support. When a child is in treatment, a family may experience emotional and economic hardships. They might require community referrals to resources for housing, transportation, food, etc. They might need emotional support or assistance for the patient, siblings, or parents and other family members. They might need help with care planning, navigating legal issues, powers of attorney, advanced directives, IEPs, individual education plans, 504 plans for their school, transitions to adult care or other things. Okay, this is the last poll that I have here. Which of the following statements about cancer treatment is true? And I will let you read through those here. Well, I'm going to go. Okay, great. I'm seeing a lot of responses of B. That is correct. So CAR T cells are a type of immunotherapy. Use the patient's own modified T cells to attack cancer. We're going to talk about that briefly here. First, we're going to talk medications. And, I listed off some common cancer medications here, but what I want to mention here is pronunciation. I get this question a lot. How to pronounce medications in the target language. So what I will often tell students and new hires, if you know or have heard the medication pronounced in Spanish, you can use, or your target language, you can use that. So for me, ibuprofen. I've heard a million people say ibuprofeno, so I will interpret, ibuprofen as ibuprofeno. However, if it's a medication I'm unfamiliar with, have never heard before, I'm typically going to say it as I hear it. So cyclophosphamide. I'm just going to probably say cyclophosphamide rather than think, how would I say that in Spanish? And then if the family says it back in Spanish or in a different pronunciation, I will try to mirror what they say. But that is my approach to it. Sometimes what I'll do with medications, if the doctor says, today, due to your levels of your blood work, we're going to start with a treatment of cyclophosphamide. I might start my interpretation, hoy con los niveles que han salido de los resultados, vamos a empezar con el tratamiento de, and then I might stop and turn to the doctor. What was the name of that medication again? And then let them say it and then just repeat it. Rather than try to hold that in my mind, that complicated medical medication name. Okay, I'm going to try to get quickly through the last things that I have here. Chemotherapy is a type of cancer treatment that uses powerful medications to kill cancer cells, stop them from growing. It works throughout the body, so it's a systemic treatment rather than a localized treatment. Can be given in different ways, often through an IV, through a vein, or through a port, but can also be delivered through pills or a shot. And children may receive chemotherapy in cycles. So treatment might be given for a few days or a few weeks, followed by a rest period to give the help to the body to recover. Chemotherapy can often be a very harsh medication and treatment. Side effects are common, but can be managed, although they are very difficult, but it can include tiredness, nausea, hair loss, low blood counts, but typically these issues will resolve when treatment ends. Chemo affects both the cancerous cells and healthy cells. So this is why you can have these side effects, because it will kill the fast-growing cells, but it might also fast-growing cancer cells, but it can affect other fast-growing cells in the body, such as in the mouth, stomach, or hair. That's why supportive care can be very important. Medications for nausea and things like that, but also psychological support for the patient that is going through that treatment. I mentioned briefly bone marrow transplant. For some of our patients that have leukemia, they may need to have their bone marrow, if it's faulty or difficult, have that replaced by, a transplant of bone marrow that is healthy and can help produce healthy cells. So when we're talking about transplants, you can have different types of transplants. It can be autologous, come from the patient's own stem cells. Allogenic comes from a donor, or can even be stem cells. All right, I'm conscious of time, so I'm going to skip some of these of talking about CAR T cell. If you're interested in that treatment, please look that up. Talk briefly about clinical trials. So that's when they're testing new treatments. Some key concepts that interpreters need to be aware of when interpreting for clinical trials. The concept of informed consent. That can only be given by a parent or guardian. Children can give assent or assent. Now, this is a key concept to pediatrics, where we want the child to be an active participant when developmentally appropriate in their treatment. So sometimes the treatment might be explained to a child in a way that they can understand, and they're given the opportunity to agree to their participation in the treatment. Other key concepts, randomization. So that's why patients might be assigned to different treatment groups or a control group. And sometimes the patient will not know what group they are in, or the provider may not even know what group they are in. So that's the blinding. And that is so that they can really know the effectiveness of a given treatment. Other important terms, eligibility criteria, who can join, principal investigator, that's the lead doctor working on the project. Interpreter tips, so clarifying standard versus the experimental treatment. So standard is the standard course of treatment for most patients that have this disease, and an experimental or clinical trial is a new type of treatment that's being tried for this type. Make sure that we're using clear, culturally sensitive language, and be prepared for emotional conversations. Always, I think it's important that we take culture into consideration. So cultural attitudes towards illness and death can be very different for our patient population than for our care team. So one of our big roles is helping our patients and families feel safe and comfortable to express their culture and their feelings about things so that the care team better understands them and can treat them better. Sometimes our families may be unwilling to disclose particular needs they might have around housing or transportation. So, letting them know we have these resources that we can help connect them to. Some of our patients and families might have an over deference to the medical team. So really letting them know we want to hear your opinion, your thoughts, your feelings about this. You are a part of your child's care team as well. Okay, trying to get through this quickly. We're almost done with my slides. I always like to talk about the code of ethics. So as interpreters, we should be very familiar with this. The ideas of confidentiality, impartiality. So let's say you have a patient that is getting a new diagnosis. You're in the care conference with the family. Then you leave, you go out in the waiting room, and that family has several family members out there. And maybe they recognize you or they know who you are, and they ask you, oh, what was discussed? You would have to tell them no, right? Because you are bound to keep confidential everything that was talked about and that. And so you could tell them, I'm sorry, I can't talk with you about that. You'll have to talk with your family directly. Things like that. Impartiality, I always like to say I am 100% on the side of whoever I am interpreting for in the moment. So if the family is upset, I have to be upset. If the doctor is being stern and scolding, I have to be stern and scolding whether I like it or not. So that's what impartiality kind of means to me in those moments. Again, accuracy, professionalism. Last one there, continuing education. And that's you guys all taking your time today to be here to continue your education and to learn more. So, I'll go to my last slide here. As we're reviewing, remember the medical setting is collaborative, different from legal interpreting. So here in medical, we're all there for the benefit of the patient. Important to be transparent always to do your pre-session. Be ready, be flexible. Remember the importance of culture and professional boundaries, your code of ethics. Then the last thing is a quote that I learned from my coworker, who's actually in the booth right next to me right now watching this webinar. But he always says, nobody cares how much you know until they know how much you care. And I think that is important for us as interpreters, that we lead with compassion always. So lastly, if you found this information interesting, if you would like to access some more webinars that myself and my team here at Children's Mercy has produced, you can go to our website here, childrensmercy.cloud.cme.com, and we have several bundles of webinars that talk about different medical specialties for pediatrics that you can access. All are accredited for credits through CCHI. And if you're interested in connecting with me, feel free to reach out via LinkedIn. All right. Thank you very much, everybody. And Analia, feel free to come back in if we've got questions or anything through the Q&A. But
Yes,
thank you so much,
awesome.
everyone, for being here and for your attention.
Wow, Paul, this was amazing. Okay, to say it was meaty, it was like a Thanksgiving feast, like a Christmas feast, like a 4th of July party. I think, Paul, we could have like 5 other webinars out of this one webinar. And we, CCC, each person on the staff, our director, John Arroyave, we're so thankful for just the amazing webinar, all the content, all the time that you took to put this webinar out of the goodness of your heart, donating your time, donating your expertise. And we had over 1,000 attendees. So
Wow.
you knock it out of the park. What a way to start 2026. I think it's going to be an amazing year for all of us in the profession, because you know what? We are together, united. We make the difference. So, just briefly, I do want to tell everyone, first and foremost, thank you so much for choosing to join us today. It's always here at CCC, we're humbled and honored that you support the profession and you choose to spend your time with us. If you needed to leave at 12:30 or right now, you may leave. If you attended the 1 hour webinar, at that moment, you will receive your certificate of completion. Please remember, allow at least 24 to 48 hours. If you have not received it, check your spam and junk folder. And that's it about it. Okay, so we are past time, which is perfectly fine. This was amazing, and we have taken a lot of time from our presenter. But Paul, you took so much time putting this presentation together. You prepare, and we're so grateful for that. Instead of taking questions, because we're over time, I would like for you to choose one question that you really, really want to answer, or just a comment that you want to make. So it's up to you.
Okay, well, thank you so much, Analia, and thank you to all the wonderful questions. I was just scrolling through and reading some of them as you were talking. I might try to smuggle a couple in because there were some great questions here that I would love to address. So one, I saw someone said, Saida Sanchez said, please address vicarious trauma. Thank you, Saida, for bringing that up, and I'm sorry that I didn't mention that. That is something that I definitely think is important, because these can be very traumatic and difficult situations for us to interpret for. And I always say that emotions are very tied to memory too. So, I was able to tell you that case that I referenced earlier about the little boy who got diagnosed with leukemia. That was probably 8 or 9 years ago. But it's still stuck in my mind. I can still remember his face. I remember his parents. And so, yes, those can be traumatic for us as interpreters. And as people were asking of how do you deal with your own feelings in those situations, for me, in those difficult or sad situations, I tend to just hyper focus in. So I'm so focused on what I'm interpreting that I'm really not leaving much room in my brain to become emotional. to deal with those in the moment. Now, what usually happens to me, it's after the moment, when I get out in the hallway, when I'm back in the office, and I realize that, oh, my hand is shaking. Like, where's this coming from? And so that is accessing the resources that you have available to you. We are very lucky here at our hospital that we have a center for well-being. We have resources for staff that they can talk with somebody if they have a difficult time. We have an employee assistance program where we can access, counseling for ourselves if that's something that we need to talk about. So I'm always encouraging my staff to take advantage of those resources. If you have coworkers and team members that you can talk with, that's, again, another resource that I lean on all the time. I have wonderful coworkers here in my office, many of whom have been here for 10, 15, 20 years. So we really support each other. And connecting to professional groups and things like that can be a great way to help with that as well. Lastly, I see on here, someone asked for narrative interpreting. Should we go into simultaneous interpreting? That can be appropriate in those circumstances. If somebody is just going and going and you don't feel like it's appropriate to stop them or interrupt them, switching into simultaneous interpreting can be appropriate in certain circumstances to help deal with that. Can I address a couple more?
Yes, yes, go ahead.
Someone
asked, go for it.
Should an interpreter cite translate any legal document for an experimental treatment? I would say no. I would say if they have legal documents or consent documents for an experimental treatment, they should get those translated into the target language. They typically have funding, research departments have funding typically to get professional translations. So because some of the language included in those experimental consents could be highly technical. So I would not put myself in a position to cite translate. I'm scrolling through to see. All right, I think those are the main ones there that I'm seeing that I wanted to address.
And you know what, Paul? We may just need to have you back. I mean, everybody just wants more. This was such a fantastic webinar. And again, to you, Paul, on behalf and to your organization, thank you so much for sharing with the entire profession and coming here to CCC to host this webinar. Thank you from the bottom of our hearts. And for everyone else, we are formally dismissed. You will receive your certificate of completion. Give it 48 hours. And I love what Paul said. He brought back the sense of humanity that we bring to the profession that no AI could ever do. Please remember why you do what you do. We do it because we embrace humanity. We care about those that cannot communicate on the same language of service, and we make that possible. Way to go, people.
Yes.
Okay, everybody, I'm going to say goodbye. Thank you, Paul. Bye,
Thank you all.
everyone. Bye-bye.